We're here today to discuss Creutzfeldt-Jakob disease, or CJD, and its implications for perioperative staff, with focus on the evidence-based practice in UH hospital policy for handling potential CJD cases. You can redeem continuing education credit for today's presentation after meeting the criteria and completion. There will be an evaluation quiz on GPS as part of your attendance for this presentation in its entirety. This presentation will provide you with a detailed understanding of the transmission of Creutzfeldt-Jakob disease and other prion diseases. You will also learn to identify the symptoms and risk factors associated with CJD and understand how it is diagnosed and the implications in neurosurgery. In addition, it will help you categorize the surgical staff role in CJD cases, including the pre-op, intra-op, and post-op stages. Finally, you will learn about the available resources for further information and guidelines on managing CJD and other prion diseases. It is important to understand that while both CJD and BSE are both prion diseases, CJD is not mad cow disease. BSE is also known as bovine spongiform encephalopathy, which occurs in cattle, while CJD, or Creutzfeldt-Jakob disease, occurs in humans. It is crucial to differentiate between the two diseases as they have different transmission and risk factors. CJD is rare but a fatal neurodegenerative brain disorder and the most common of the human prion diseases. A prion is an abnormal protein that can be both genetically inherited and transmitted through contact with infected tissues or bodily fluids. The abnormal prion protein accumulates within the brain, causing brain damage and leading to a range of symptoms, including dementia, muscle stiffness, and loss of coordination. Infectivity of prion diseases is found most often in higher concentrations within the CNS, or central nervous system. This includes the brain, spinal cord, and the eye. These tissues are considered high risk for prion transmission. Other tissues and bodily fluids have varying degrees of infectivity. CSF, or cerebrospinal fluid, the kidney, liver, lungs, lymph nodes, spleen, and placenta are considered to have lower infectivity compared to that of CNS tissues. On the other hand, tissues such as adipose tissue, adrenal glands, gingival tissue, heart, muscle, intestine, peripheral nerve, prostate, skeletal muscle, testes, and thyroid glands are considered to have no detectable infectivity. Bodily fluids such as blood, tears, nasal mucus, saliva, sweat, serous exudate, milk, semen, urine, and feces are also considered to have no detectable infectivity. However, caution should still be exercised as prion disease transmission through blood and other bodily fluids has been reported in rare cases. Human transmissible spongiform encephalopathies, or TSEs, are classified into three categories: idiopathic, familial, and acquired. Idiopathic TSEs include sporadic Creutzfeldt-Jakob disease and sporadic fatal insomnia. Familial TSEs include familial CJD, fatal familial insomnia, and Creutzfeldt-Straussler-Scheinker syndrome. Acquired TSEs account for less than 5% of all TSEs and include variant CJD, iatrogenic Creutzfeldt-Jakob disease, and KURU. The next couple of slides will go through some differences on the types of CJD from Case Western's resource on CJD, as they are our local surveillance center. Sporadic CJD has an unknown etiology. It can present with features of ataxia and dementia. Sporadic can have a later age of onset than other types and present with psychiatric symptoms including speech deficits and cognitive impairment. Genetic CJD resembles sporadic. It is marked by rapid deterioration of neurologic and cognitive functions from a mutated prion gene. It presents with personality changes, anxiety, depression, memory loss, impaired thinking, vision abnormalities, insomnia, difficulty speaking and swallowing, myoclonic jerky movements, tremors, and weakness. Impaired balance and instances of falls also may occur. Genetic CJD usually presents in midlife, which is sooner than the onset of sporadic. The third type of CJD is acquired. Kuru is within the acquired category and is an acquired form that can result from cannibalistic behaviors. Iatrogenic CJD is important to understand as perioperative staph, as it is linked to the contamination of neurosurgical instruments and some specific human graft materials. Variant CJD is related to consuming contaminated animal products like cows with BSE. The symptoms of classic CJD can present similarly to various types of dementia. These symptoms include cognitive impairment, difficulty in concentrating, learning, and decision-making, as well as ataxia, which is a loss of coordinated movements. Some cases may also have visual symptoms or hallucinations. Unfortunately, the rapidly progressing nature of the disease and the lack of specific symptoms mean that it can be misdiagnosed as a non-specific psychiatric symptom or anxiety. The prognosis for CJD is typically poor, with death occurring within 6 months of the onset of symptoms. It's knowledge check time. What type of CJD are we most concerned with preventing in the OR setting? The correct answer is acquired or iatrogenic. This is the type most concerning for the OR because it can be transmitted through medical procedures, including neurosurgery. It is important for surgical staff to take the appropriate precautions to prevent transmission of CJD and other prions within the OR setting. According to the CDC, or Center for Disease Control and Prevention, a definitive diagnosis of CJD can only be made through brain tissue testing using standard neuropathological techniques, including histology and immunohistochemistry. In some cases, a Western blot test that confirms protease-resistant prion protein, or PRP, may also be performed. These tests are typically performed after the patient's death, often during an autopsy. It can be challenging to diagnose or rule out CJD in living patients. However, if a patient shows certain symptoms such as rapidly progressive dementia with myoclonus and other neurological symptoms, a probable diagnosis of CJD can be considered. Other tests such as MRI, brain imaging, and CSF analysis may support the diagnosis of probable CJD, but they cannot definitively confirm or rule out the diagnosis. The real-time quaking-induced conversion, or RT-QuIC method, is a newer diagnostic test developed in 2010 that can help identify the misfolding of the prion protein within the CSF, or cerebral spinal fluid. This method is useful for detecting sporadic and variant types of CJD. In particular, RT-QuIC is often used to confirm a diagnosis of CJD when a patient has a combined neuropsychiatric symptoms and a positive result in the RT-QuIC test. This would mean that the patient would be positive for a probable CJD diagnosis. Neuropsychiatric symptoms can include cognitive impairment, difficulty concentrating, and hallucinations, among others. The presence of these symptoms combined with the positive test can strongly suggest the diagnosis of CJD. However, it would still fall within that probable CJD category and require brain tissue testing, as discussed earlier, to finalize a diagnosis. With the second method to be diagnosed with probable CJD, a patient must exhibit symptoms of dementia along with at least two of the following. Dementia refers to a decline in the cognitive function that can affect memory, learning, and decision-making, and other mental processes. In CJD, this dementia is often accompanied by other neurological symptoms such as myoclonus, which is a sudden jerking movement of the limbs or face. Visual and/or cerebellar signs include difficulty with coordination or balance. Extrapyramidal or pyramidal signs can manifest as slow movements, muscle stiffness, or tremors. In some cases, patients with CJD may also experience akinetic mutism, where they are conscious but unable to initiate goal-directed behavior or show emotions. It is important to note that these symptoms are not unique to CJD and can be present in other neurological disorders as well. An additional criterion from the following is also needed for a probable diagnosis using this method. A probable diagnosis of CJD can be made in a patient who exhibits at least two clinical signs, such as myoclonus, visual or cerebellar signs, pyramidal and extrapyramidal signs, or akinetic mutism discussed on the previous slide, along with a positive result on at least one of the following lab tests. An EEG suggested of CJD with periodic sharp wave complexes, a positive 14-3-3 CSF test in a patient with a disease duration of fewer than 2 years, high signal in the caudate putamen region on an MRI brain scan, and at least two cortical regions, temporal, parietal, or occipital, either on diffusion weighted imaging, DWI, or fluid attenuated inversion recovery, FLAIR. Genetic forms of the disease can be determined through genetic sequencing on blood samples. As previously mentioned, a definitive diagnosis of CJD still requires brain tissue testing using standard neuropathological techniques. Knowledge check time. Which of the following are movement disorders that can be symptoms of CJD? Select all that apply. Ataxia and myoclonus are the correct answers. These are movement disorders that can be symptoms of CJD, followed by rigidity. Patients at high risk for CJD include those with rapidly progressive dementia, those with a familial history of prion disease, recipients of cadaveric dura mater grafts, human pituitary gland hormones, and corneal transplants, as well as those who have been exposed to contaminated instruments. It is important to understand how and where to locate this policy. On the UH Intranet homepage, if you select Menu in the top left corner and drop down to Policies and Forms, you will see a drop-down arrow for System Policies. There you will be able to search for CJD or related terminology on Policy Stat. You can also look it up with its Policy Stat ID listed below, 13122-329. Please take some time to review this policy in addition to this module. This is an image of the CJD card that you will obtain per the IC-17 policy for a potential CJD case card. It lives in CSP and will be sent to the OR on request. So what can you expect to find in the CJD cart? As we discussed earlier, in order to prevent the transmission of prion diseases to another patient from contaminated items and equipment, there are some supplies that we will need to obtain prior to the start of the case. The main contents of the CJD cart will include red biohazard bags, biohazard sharps containers, pink labels to mark the biohazard waste for incineration. The cart also contains disposable instrument trays to help reduce the amount of waste, as items cannot always be reprocessed, as they are not easily sterilized after prion exposure. The other items that you may be less familiar with are the two concentrations of the NaOH, which is sodium hydroxide, and the base neutralizer. The two concentrations of sodium hydroxide will be further discussed. The recommended disinfectant for environmental surfaces contaminated or potentially contaminated during a procedure where there is a risk of CJD transmission, the 1N sodium hydroxide solution would be appropriate. It is used as a premixed solution in the 1N concentration and will use to be disinfecting room surfaces that potentially are contaminated with infectious tissue or fluid. After disinfection, the remaining solution on the surface should be allowed to remain wet. Excess solution will be discarded as hazardous waste and should not be poured down the drain. Do not save the solution to reuse at a later date. To neutralize the 1N sodium hydroxide, the Spillfighter base neutralizer will be sprinkled over to allow saturation after the 1 hour. It is important to make sure that all of the liquid is solidified and that the solution is neutralized. In case of any doubt or questions, the safety department should be contacted for guidance. If there is an intact skin exposure to CJD, immediately remove any contaminated clothing and rinse with the 0.1 N sodium hydroxide. And flush the affected area with water for at least 15 minutes while avoiding contact with unaffected areas. Seek medical attention as needed according to the hospital exposure protocol. Knowledge check. Which strength of sodium hydroxide is appropriate to use if a glove tears without injuring the skin barrier and the staff member is concerned with potential CJD exposure? 0.1 N is the appropriate strength for intact skin exposure. Prior to the patient transfer to the OR, you should call CSP at 50101 to request the CJD cart. Make sure that the cart is available and stocked with supplies indicated in the policy. Ensure form Attachment A is completed. Attachment A is the pre-op checklist that is filled out before the case if we have any concern for CJD. It is completed for a concerning patient with symptoms and the indication for a biopsy to be completed. Please review these forms attached to the policy. Knowledge check. Who and when should CJD risk assessment tool be completed for? The form directly states, the physician will complete the following checklist and return this form back to the OR scheduling office. This form is done early so that the case can be scheduled appropriately and that perioperative staff have time to get the preparation complete and the essential supplies and equipment obtained. Additionally, you will inform and have the following team members sign Attachment B prior to starting the case. This ensures that interdisciplinary communication has occurred and all involved parties are aware. Each person signing should also review the policy. This is what Attachment B looks like and where you will collect all the appropriate signatures. The CJD policy contains attachments to help you prepare for a potential case. In general, the approach is to consider the minimal supplies needed to safely do the case. Power tools like the neuro drills used for regular boreholes are avoided. This is because they move at high speeds and could release prions the same way as bone dust is scattered, but it would not be visible to the naked eye. Manual drills help to minimize this risk. A suction tree should be used with a canister in place of a Neptune to minimize the equipment in the room and to be more easily contained and sent for incineration. In regards to the OR bed and table, the gel pad should be taken out of the room, and disposable silk tape would be utilized to secure the patient in place of a seatbelt so that it would not need to be disposed and wasted. Signage should also be posted on the doors to decrease the unnecessary OR traffic and ensure only required personnel are in the room. These guidelines are aimed at reducing the risk of transmission of CJD in the OR setting. All personnel involved should be aware of the transmission risk and protocol in place. Only essential equipment and personnel should be present in the OR. Any disposable equipment should be used when possible. Any equipment that needs to be reused should be properly quarantined, cleaned, and disinfected according to established protocol. However, this is not done at UH. We will follow our policy and incinerate items used in the case. All equipment in the room should be covered to prevent contamination. Any specimens should be double bagged and labeled according to policy. These measures help to minimize the risk of transmission of CJD during surgical procedures. The pre-op checklist that is filled out prior to the case for patients containing CJD can be found within the policy. The pathology department should also be notified in advance when a case of potential CJD is scheduled. The order form for pathology is known as Attachment C. This should be used. No frozen sections will be sent for these patients. When the specimen is removed, the Mather Pathology Lab should be informed at extension 42216. After 5 p.m., the pathology resident on call should be paged. After the CJD specimen is removed, it should be delivered to the Mather Pathology Lab on a saline-soaked telfa in a labeled specimen container that is placed in 2 biohazard bags along with the completed pathology rec form. It is important to document the delivery to pathology on the sign-in sheet and hand the specimen directly to the pathologist without ever leaving it unattended. Additionally, ensure that the Case Western Reserve National Prion Disease Pathology Surveillance Center has been contacted to report the case. Knowledge check. Which pathology form should be utilized for a CJD biopsy specimen? job. A is the correct answer. The Case Western National Prion Disease Pathology Surveillance Center form is attachment C. You will see here the intraoperative section of the checkoff form. You will see here the intraoperative section of the checkoff form that goes through instrumentation, specimen handling, supplies, and waste disposal guidelines. Take a moment to glance over and further review this within the policy. Knowledge check time. Where should a medication that was in a CJD room be disposed of? The correct answer is B, the biohazard bin on the CJD cart. Medications in the room should be disposed of through incineration. Typically, unused medications could be taken to a black waste disposal unit, but with the added potential for prion exposure, the contamination potential should not be risked. Medications can still be used in these cases. If the medication was removed from the room prior to the patient entering the OR, it could be returned to pharmacy. But once in the room with the patient, it should be sent for incineration, even if unopened. Best practice is to minimize supplies in the room. The anesthesia carts are covered in plastic, so medications can be retrieved as needed and not needing disposal unless outside of the protective impervious covering material. This is the postoperative section of the checklist from IC-17. It outlines the disposal of waste and cleaning of the OR and the equipment. Please take a moment to review this and review more thoroughly through the link and policy. Here is a review slide of some of the items for CJD. Medications should not be returned to pharmacy unless removed prior to the patient entering the OR. Specimens should be double-bagged and hand-delivered to the pathologist while following proper protocol. Additionally, any trash that may have come in contact with high or low infectivity tissue and fluid should be incinerated. Trash removed from the room prior to the patient entering the room can be disposed of without incineration. This can help to minimize the amount of waste for incineration to ensure that all materials can fit back on the CJD cart. To ensure proper handling of specimens and minimize the risk of transmission, all personnel involved should be aware of the risks and protocol. Only essential equipment and personnel should be in the OR. It is recommended to plan ahead and utilize disposable equipment and properly dispose of instrumentation used in cases. No instruments used in probable CJD cases will be reprocessed at CMC. Staff should advocate for the use of disposable instrumentation and reduce waste and the volume of supplies needed to be in the room and ultimately sent for incineration. Impervious coverings from the room will also be bagged and included on the case cart for incineration. Specimens should be double bagged and labeled according to policy. The completed pathology rec form, Addendum C, from Case Western must accompany the pathology specimen After the patient enters the room, everything with a potential or known contamination of high or low infectivity tissue or fluid becomes red bag trash that will have a pink label placed on it for incineration and must be contained within the CJD cart. Instruments for the case will be placed in the sharps container within the CJD cart and returned on that cart. Fluids used throughout the case will be solidified, including the suction tree canister contents. Prior to and throughout the case, think minimal on what needs to be in the room and the waste that will need to fit back on the case cart. Room surfaces that may have contacted infective tissue or fluids will be cleaned using the 1N sodium hydroxide and allowed to remain wet for 1 hour before neutralizing with the solidifier. When all materials and waste for incineration are confined within the CJD cart, it will then be sealed and quarantined until it is picked up for incineration. Please ensure that everything is labeled accordingly. The World Health Organization, or WHO, provides important guidelines for healthcare workers when dealing with CJD cases. Staff should be aware of the exposure risk and trained accordingly. Please take necessary precautions to protect yourselves by following UH hospital policy and seeking further information from these resources for specific guidelines for instrument cleaning and environmental care. The AORN recommends that a hospital have guidelines for care of suspected or confirmed CJD cases. These recommendations cover several areas, including staff training, protection, environmental cleaning, instrument cleaning, anesthesia equipment, and pathology. We dove into these topics already. The guidelines stress the importance of staff training and awareness of the transmission risk and protocol. Please do your part and review the protocol. In regards to instrument care, recommendations emphasize the use of single-use or minimal items to be incinerated. Power equipment should be avoided. This includes drills and power saws. Implants should be limited to only what is needed and incinerated if it was on the surgical field. AORN guidelines outline the approved method to process CJD instruments, but the cost and compliance of following these standards is high. UH committees have agreed to avoid this reprocessing of instruments within a CJD case. Overall, these recommendations help to implement appropriate infection control measures and awareness. The recommended practices under the section of environmental cleaning note that disposable linens that cover work surfaces should be disposable, impervious materials that can be removed and incinerated following the procedure. Environmental surfaces should be cleaned with 1N sodium hydroxide, ensuring that 60-minute contact time. Contaminated supplies and instruments will be contained within the CJD cart. Liquids used in cleaning are going to be solidified. Please remember to label accordingly. If further information is required, you can look up the material safety data information for use with sodium hydroxide. This can be located on the UH intranet. The National Prion Disease Pathology Surveillance Center was created in 1997 by a local pioneering doctor from the Neuropathology Division of Case Western Reserve University School of Medicine. The center operates under the sponsorship of the CDC, the Center for Disease Control and Prevention, and reports to the CJD. Like similar agencies in Europe, the center monitors cases of CJD in the United States. The center acquires samples of tissue to make diagnoses of prion diseases. The CJD Foundation is located in Akron, Ohio, and serves as a resource for families and healthcare workers and patients by providing education, information, and support. The Foundation's website is listed here. It offers a variety of resources and information related to CJD and other prion diseases. The Foundation offers support to families, patients, and healthcare workers to help alleviate fears and provide assistance. This includes education for patients and families, education for healthcare professionals, and the emphasis of the importance of continued research. Their helpline offers information for physician referrals, care planning, hospice, home health care, autopsy, and funeral arrangements. Here are some further evidence-based practice organizations if you would like to look more into the topic of CJD. Remember to access the policy and attachments to aid in the process if you ever are involved with a suspected CJD case. The attachments provide a great checklist to help throughout this case. Here Here are the references for the presentation. Thank you for listening. This concludes the presentation.